Uh,
Yep.
can I guess, if I'm in presenter view, I don't know if I can still see the chat. There it is. Okay. All right.
I think in the past, Derek, people have just unmuted and interrupted if they have.
Okay. That's fine too. Interrupt me. All right. Today, and just anyone interrupt me, let me know if they can't hear me. Today, we're talking a little bit about total arthroplasty complications and a little bit about sort of diagnosis and a little bit about management. But we're going to leave sort of revision principles and a lot of the management to Dr. Hansen for the next lecture. We're going to go a little bit over the epidemiology of revisions in general. I'm going to talk about some acute surgical complications, and then also sort of what I define as kind of non-acute surgical complications, just because obviously the management is very different when you're in surgery than when you're sort of out of surgery. Some caveats to this are that this is sort of a broad general overview of complications. And looking back at sort of what we do in core arthroplasty lectures, as well as what we do on the arthroplasty rotation, I actually wanted to focus a little bit more on acute surgical complications because we don't actually talk about that quite as much. And the other caveat is that certainly each of these things could be their own lecture in entirety. So I apologize if we don't quite get through it all, or if there's sort of limited information for each one. So epidemiology of total hip revision in general, there's been a number of studies. This is looking at sort of the US. There's these classic Kurtz JBJ essays from 2005 and 2007 that look at sort of the revision of burden of revisions as well as the burden of primaries, with the sort of relatively explosive demand in the projected for the increase in primary surgeries. The demand for revisions are going to rise significantly. Overall in the US, it seems that the indications for revision still favor instability and dislocation being the primary, followed closely by mechanical loosening and then infection. We'll see how that changes over time. I suspect as highly crossing polyethylene becomes sort of the predominant bearing surface for patients who have had their hips in for a long time, then infection will probably eclipse mechanical loosening. What's interesting to note too is that the revision burden for total hip arthroplasty is actually higher than the revision burden for total knee, meaning even though there are more total knees out there, there's a higher percentage of patients who have a hip who need to be revised than for total knees over time. This is largely due to probably mechanical loosening over time. Worldwide, the numbers look a little bit different, with a stronger predominance for aseptic loosening over dislocation. This probably has to do with the fact that there's a larger percentage of cemented acetabular components over time, or cemented components in general over time outside of the US. But overall, again, the three primary causes for revision are aseptic loosening, instability, and infection. What's also important to note about the revisions is that it's time dependent, particularly with loosening. So if you look at the causes for revision over time, at under 2 years, it's predominantly, under 2 years and then 2 to 5 years, it's predominantly instability and infection. And then aseptic loosening becomes the predominant mode of failure as it gets further out. So let's move on to acute surgical complications. So we're going to talk a little bit about vascular injury, nerve injury, and acute periprosthetic fracture. Venous thromboembolism is listed as an acute surgical complication in the purple book. However, we're not going to cover that today because I think you guys have an entirely separate lecture on that, and it's a relatively sort of larger topic. I'd love to say this to my patients at some point to actually prescribe it to them, but I can't. So the non-acute surgical complications we're going to talk about today include heterotopic ossification, limb length discrepancy, instability, osteolysis, which I coupled with aseptic loosening, and then we're going to briefly touch on alternative bearing complications. We're not going to cover periprosthetic infection today, and we're also not going to cover overall periprosthetic fractures outside of the sort of the acute setting, because those are covered by Dr. Toogood, and periprosthetic infection is its whole separate lecture. So in terms of vascular injury, this is an exceedingly rare complication in the literature with a rate of 0.1 to 0.3%. However, despite its rarity, it can be an absolutely devastating complication. So I think it's really important to keep in the back of your minds all the time. If you look at sort of how many major blood vessels are kind of hanging out relatively close to the hip joint, and the inner side of the pelvis, this terrifies me on a daily basis, and I think it should also give everyone just cause for concern. The main causes described in literature are drills or screws and retractors. I think it's probably much more likely to be the drill than the screw that causes the problem. But it's certainly possible and described that screws can cause some of the delayed issues as a vessel sort of rubs over a screw over time. There's either kind of two presentations. There's the immediate presentation, which includes severe hemorrhage, dissection, or some kind of plaque rupture, not a plague rupture, I misspelled that. And then there's the delayed presentation, which essentially is pseudoaneurysm or fistulas. Sometimes the delayed presentation can actually become acute when a pseudoaneurysm can actually rupture. The cited risk factors for vascular injury include any revision surgery, the ones you think about in terms of standard vascular risk factors where the vessel has less compliance or prior surgery. An area of the body that's been irradiated where the soft tissues don't have much compliance either. And then conditions for which there's a sort of more dissection, more traction, and more disruption of the anatomy, including congenital dislocation, dysplasia, or infection. A significant percent of vascular injuries result in lawsuits, and it's important to remember that any sort of delay in diagnosis can lead to significantly worse outcomes, including amputation and death. So when we're talking about vascular injuries, it's important to remember the quadrants. I'm not going to belabor the potential injuries with each quadrant, just remembering that the posterior superior is the safest zone. If you look at the image on the right of your screen, those little screws A and B here are screws that were placed through the anterior superior portion of the acetabulum and come out right next to the external iliac artery. So obviously that's the danger zone. I asked Dr. Reese once during a revision case where we're having a difficult time finding screws, whether or not he would ever place screws there, just because if there was good bone there, and he's relatively fearless, and he said no. So therefore, I do not either. Another important thing to remember is not just the screw placement, but the screw length in terms of injuries. This slide shows sort of the bone depth of the acetabulum on average. Now remember, this is sort of the bone depth. If you're kind of drilling straight in, you can definitely put longer screws in depending on the angle. But the acetabulum, even, and this is before you've taken away any bone with your reamer, is really not that thick. So there aren't that many places where if you kind of drilled straight in, you wouldn't necessarily be worried about hitting something. And, sometimes we sort of fail to remember this, but we get lucky. This is an image from a surgeon who is no longer here, but this case was done at UCSF. This was revision acetabular component. The component is placed relatively vertical, which I think is probably partially what leads to the errant screw placement. But you can see on the left that this surgeon got quite lucky in that the screw threaded right in between the artery and vein. And, this patient, if that drill had been 1 millimeter off one way or another, could have, could possibly have died on the table. So definitely something to pay very, very close attention to and always keep in the back of your head. Another important injury mechanism, particularly in the area where we're doing a lot more anterior hips, is retractor placement. So, our normal retractors go right over the anterior wall of the acetabulum. If you look at some schematics, that retractor comes frighteningly close to the vessels as well, depending on where it's placed. Now, if the retractor is on bone and capsule, then the iliopsoas, sometimes erectus, actually will sort of protect the vessels from it. But if that retractor is placed errantly within the muscle or over the muscle, then that retractor can very easily come into direct contact with the vessels, and depending on sort of how it's placed and the angle at which it's placed and the sharpness of the retractor can cause direct injury to the vessels. This also can, depending on how hard we're pointing on the retractor, can cause things like plaque rupture or intimal tears, even if the retractor isn't directly on the vessel itself. A couple important principles to remember is that the more superiorly you place the retractor in the acetabulum, the safer you are. Now, that doesn't give you as much visualization, but if you're trying to figure out where to replace the retractor from the get-go, then placing a little bit more superiorly is a little bit safer. And then once you have better visualization, you can place it more inferiorly under direct visualization. But this is why this part of the procedure, placing this retractor in the anterior acetabulum, certainly makes me worried every single time I do it, because this stuff does happen. One of our former fellows last year called me after having this complication happen to him intraoperatively. This complication happened to one of my attending surgeons, a very, very experienced surgeon during fellowship. And he had placed the retractor, so it's real.
Hey, Dr. Ward, can I ask you a quick question here?
Sure.
In that case, are more people getting like a true hemorrhage and like a slice through it, or do people get more of like an aneurysm and delayed presentation with it, or is it kind of all over the board?
Yeah, it's a good question. It's a little bit all over the board. It's such a rare event that it's probably hard to say that it's like 1% of one thing versus another. But the two cases I just referenced, the patient had an acute drop in blood pressure and and rise in heart rate there, and the patients exhibited hemodynamic instability consistent with a massive hemorrhage. The thing is because often the tear is actually or the injury is intrapelvic, you may not see the hemorrhage sort of come pouring out of the acetabulum, especially because the retractor is kind of right there, sort of in place where it might come out anyways. So sometimes in both those cases, the first that from what the surgeons told me, the first sign was not actually bleeding that they saw, but it was hemodynamic instability. But it definitely, the delayed presentation is much more like the intimal tear and that kind of stuff, and that may come from more vessels that have lack of compliance and sort of pressure on the retractor.
Sorry, and then just a quick follow-up question. If you do suspect that this does happen intra-op and there is an acute drop in blood pressure, besides calling vascular surgery, in the immediate action, what do you typically do? Do you just put some pressure in the front of it? Do you actually try to dissect that out?
Yeah, it's a good question. I mean, obviously vascular is your first call. I think that in the absence of I don't know exactly what I would do in the immediate situation. I think the first thing I would probably try to do is I would probably try to put direct pressure on the vessels in the femoral triangle with my hands, and simply see if I could, halt the bleeding until the vascular surgeon got there. If you're doing an anterior hip replacement and an ambulatory surgery center and the vascular surgeon is like an hour away, right? Then, the patient's going to die. And I think you're probably obligated to try to dissect and find the bleeder and see if you can clamp it off. That being said, I don't have a lot of confidence in my ability to do that very well.
Got it.
It's certainly a scary situation. for sure. All right.
I think rule number one is make sure everyone in the room knows what's going on, though, right? So you got to tell anesthesia, tell the circulator, tell them to start getting blood, tell them to start getting, get the boat loaded as fast as you can, and then get a finger on there.
It's better to be wrong, right? And get everyone on board with the problem than it is to put your head in the sand about this kind of thing.
Got it.
So, but yeah, I don't know, Jeff. Have you ever? I've never seen. I have yet to be involved in this particular complication in a case of mine, but I haven't heard of a surgeon having to sort of dissect the vessels and see if they can clamp it off.
The only bad vascular issue I was a part of, actually, I think Musa was a part of too.
Don't get me involved in this one.
What's that?
Was that the one with when Chance was a fellow?
No, this was one at the county where we're doing I forget which type of I think it was a posterior approach.
Is that the one that was you guys found in PACU based on the peripheral pulses and
correct?
Yeah, patient had a pulseless foot on post-op check.
During the case, we placed a retractor anteriorly, and there was a big flash of like a ton of blood really fast, and then pretty much just stopped on its own. So continued the case, finished the case. The wound was dry. And then in the PACU, patient had lost pulses. So good catch by Musa, catching a pulse change in the first hour or two, and found to have, I think it was I don't know if it was a dissection in the femoral artery or some issue with the femoral artery had gotten injured by the retractor, and it somehow spasmed itself off that it hadn't bled out entirely. That's the only one I've been involved in.
Okay.
So then did they open the patient up again, or did they go to IR?
They opened and did some sort of vascular repair.
Yeah, that usually you don't have time to necessarily go to IR if there's hemodynamic instability. And remember, a lot of these are not necessarily done on a table where where the vascular team can come in and do an IR type procedure, right? Very easily. So usually they'll often have to just go right to an open approach. So, but it does, it's important that, when you call vascular surgery, you also have them call for the vascular sets before the surgeon even gets there, so they can scrub in and just do it as quickly as possible. The case when my attending had in fellowship was like that, where they literally just open up the abdomen. Not a hip, but there was a case in fellowship that was done at our specialty hospital. There was an anterior approach to the spine where the spine surgeon was doing his own dissection and got into a vascular issue, and they actually had to fly the vascular surgeon by a helicopter up from the city hospital in order to deal with it. And they sent the entire staff of the surgery center basically driving around all the closest hospitals to get as much blood as they could to keep the patient alive in the meantime. So, I'm saying that to freak you out intentionally because it should scare you, because avoiding these issues is definitely important. And also perhaps choosing any high-risk patients to not be done in a setting where you don't have the expertise to deal with this is also important. So, and just again, to sort of hit home the point of how close these vessels are, this is, an MRI scan with a localizer. And if you look at sort of right where you might place the retractor, this kind of yellow line in the anterior lip of the acetabulum, the vessels are very, very close by. So they're right there. All right. So in order to prevent these, I think one of the single most important things is the careful placement of retractors on capsular bone. If you can't physically see the retractor being on the capsule or on the bone, then don't just sort of push it in harder and see if it sticks. Go back and directly visualize it being on the capsule of the bone before you go further. I think one thing that can definitely help is to keep the vessels off tension when placing retractors. Now, this, when patients are allowed the cubis position, almost always the femoral artery is actually, off traction because generally the hip is flexed when you're placing this retractor. But that's not always true. And certainly for revision surgery or surgery with heterotopic ossification or anything else, the retractor can definitely go awry. But in the when you're doing an anterior approach, flexing the leg when you're placing that retractor initially, I think is a reasonable thing that might actually take that vessel off tension. I think it's really really important to be careful when you're drilling and placing your screws, and also to pick screw lengths based on your quadrants. One simple trick to avoid plunging, even with a flexible drill bit, is just flex your bicep when you're drilling, and that will sort of help keep you from plunging. I also think it's important to be aware of the risk factors for specific patients. And in some cases, it's actually maybe worthwhile to get vascular surgery involved preoperatively, particularly for revision cases or cases where you have a vessel very close by a revision implant or a protrused implant. There's been a couple scenarios we've had where we've essentially had the vascular set, in the room but not open, the vascular surgeon just kind of hanging around. And then there was one case I was involved in fellowship where we actually had the vascular surgeon feed up a balloon catheter from the other side into the common iliac artery that we could inflate if we got into a problem, and he was close by. So that was a much bigger revision case, not a primary case, and the cup was sort of right up against the vessels. So in terms of diagnosis and treatment, in terms of if there's an acute presentation, it's really important to have sort of a rapid diagnosis. Obviously, intraoperative hemodynamics outside of what you see in the operative field are going to be your most important sign. Now, for generally healthy young patients, the hemodynamics respond relatively slowly to blood loss. So, once you've gotten to the point where you have a drop in blood pressure or a significant drop in blood pressure, there's already a fairly significant problem going on. It's critical to check peripheral pulses before and after surgery. I think all of us have gotten in the habit of this, of doing this, but it's really important, as Moose's catch at the General illustrates, that you don't blow off abnormal findings and say like, oh, they have a cold foot, or it'll come back. Like if there was a pulse before surgery and you can't find a pulse, you need to prove to yourself that there's either a pulse by Doppler or that there's no significant change in pulse. Rarely you'll see sort of an evolving groin mass and the hematoma formation at that area, but given that there's a potential space, for that to go into the pelvis, that's probably not as common. Obviously, your first call is to vascular surgery. Usually some kind of direct repair or bypass is necessary, plus or minus prophylactic fasciotomies, depending on how long it's been going on. If there's a delayed presentation, for instance, there's a change in peripheral pulses, or you suspect an aneurysm or something like that, and the patient's in clinic, if it's not an emergency, then a full workup with either a CTA or ABIs and a vascular consult is warranted. Once again, it's better to sort of find nothing than to ignore something that might become a problem down the road. All right, let's move on to nerve injury. So nerve injury in the literature in terms of sciatic and femoral is quoted as somewhere between 0 and 3%. I always find it's amusing when any study quotes as 0%, but that's just me. We'll touch briefly on lateral femoral cutaneous nerve injury. Depending on which study you read, it's somewhere between a 10 to over 80% of the literature. I think that just depends on the sensitivity of how they're asking the questions or doing the study. As you can all remember, the femoral nerve is very close to the vessels over the anterior column. The sciatic nerve is not that far away over the posterior column. So both are certainly at risk when we're doing anything with the hip. The main causes we think of are traction, some kind of direct injury, or a slow compression, which generally is an evolving hematoma. There's actually a lot of different theories about how a traction injury may actually work. Some people postulate that most of the sciatic nerve injuries are actually a sort of compression/traction injury on the nerve created by the gluteus maximus tendon when you put the hip in a certain position. Other people theorize that it's just, sort of how much we're moving the hip around. And then there's always the question of limb lengthening. So in terms of sciatic nerve injury, it's classically associated with any posterior approach, which just makes sense because you're in that area. It is associated with limb lengthening, although I sort of put a question mark up there because there's been a couple studies that actually questioned that. This was a study that looked at limb lengthening for replacement arthroplasty developmental dysplasia and showed really no correlation between the actual sciatic nerve injury and limb lengthening, even though we're classically taught that. It's possible that there's sort of a true and unrelated thing here where the patients that we have to lengthen the most are the ones that we're also sort of doing the most work with, pulling the most tension on, are in the hardest, longest cases. And so, by that sort of, that sort of rationale, there's going to be more nerve injuries. Dysplasia cases certainly have a higher rate of nerve injury, and then any post-traumatic case also has a higher rate of nerve injury. The perineal branch is the most commonly injured. Does anyone know why that is, or why we theorize that is? Any
where
ideas?
the fibers are located in the nerve itself?
Yeah, so it's the distribution of fibers in the nerve. So if you look at the tibial division, the perineal division, the tibial division at that level actually has a significantly higher amount of connective tissue in between the fascicles compared to the perineal division. So if both are squished, the nerve fibers in the tibial division have somewhere to go, and the perineal division don't. That's the theory, anyways. In generally, a sciatic nerve injury has a long and often incomplete recovery. So if there is a nerve injury and it isn't due to a hematoma that's evacuated quickly or something, then it can take many months to resolve. If it doesn't fully resolve, then the ultimate sort of worst functional outcome is the patient will need to wear an AFO. That turns out to be a functional consequence that a lot of patients actually can live with in terms of their quality of life. Especially with the way AFOs are designed these days. The hard part is that for a patient who was otherwise healthy and came in for a primary total hip replacement to have that complication and then end up with a brace for the rest of their life is a tough pill to swallow. I think Jeff and I have definitely had revision patients that we've known who have to wear an AFO who simply just don't think it's that big a deal. I've also definitely met patients who had a primary hip replacement, and had a bad outcome and had a sciatic nerve injury who are very unhappy with the fact that they have to wear a brace for the rest of their life, which I can certainly empathize with. In terms of femoral nerve injury, this is generally associated with an anterior approach, although if you look at the femoral nerve injury rates from approaches, it happens from any approach, just like sciatic nerve injury can happen from any approach as well. It's probably less common overall than a sciatic nerve injury, although it does happen. The quoted rates in the literature are relatively low if you sort of look at this table. What's particularly important about femoral nerve injury is that it has a pretty bad functional outcome, and it almost never fully recovers if you really sort of dive down and look at people's symptoms. This sort of this plot on the lower right is looking at final follow-up in terms of symptomology, ability to climb stairs and everything else for all of these patients. And even at final follow-up for some of these patients was years later, none of them normalized. Some of them got relatively close, but very few patients had full recovery of function. If the nerve doesn't recover at all, then patients often end up requiring some kind of lockable knee brace and a gait aid in order just to ambulate. So it can have a really bad functional outcome. In terms of lateral femorocutaneous nerve, it's a question we talk about a lot because of the anterior approach. The injury to this nerve is largely due to the anatomy of the anterior approach and the proximity of the nerve to the to the incision, as well as the placement of the retractors and sort of the stretch on it. Overall, when we're talking about hip replacement in the anterior approach, it has generally few functional consequences and rarely in the long term impacts patient satisfaction. Although I read a review once, but I don't think the study ever got published, that looked at, it was trying to discern whether or not patients were aware of the possibility of the injury beforehand. If you don't counsel patients that this can happen before the surgery and talk to them about it, and then they have it happen, then they get frustrated by it because they didn't expect it. But if you tell them that their thigh there's a good chance that their thigh is going to get numb and that it will likely recover, but it may not, then even if they have the thigh numbness, most of them seem to be okay with it. And it doesn't seem to overall impact patient satisfaction scores in general. It's important to distinguish lateral femoral cutaneous sort of neuropraxia from what we think of in the literature as myalgia paresthetica. So this is sort of a more severe injury to the nerve itself. It can actually be spontaneous or iatrogenic. Can be related to obesity, pregnancy. In orthopedics, it's actually most common from prone positioning or some kind of prolonged lithotomy. It can happen like when we used to put patients in an up leg holder during fracture surgery. It's not uncommon during spine surgery. I think this actually happens not from sort of a direct pressure on the nerve like in an anterior total hip, but actually from a point of compression where sort of the nerve crosses over the pelvic brim. And this entity can actually be quite painful. It can happen after an anterior total hip, but it's extremely rare. But if this happens and it's painful, then there are some treatment strategies, both in terms of regional anesthesia and injections and sometimes neurectomy. In terms of the time to recovery for a lateral LFCN palsy, it can take a while. So you have to counsel patients on that as well. Any questions about that before we move on? Okay. So in terms of diagnosis and treatment of nerve injuries in general, the most important and relevant one for us is a careful physical examination and compare that to a preoperative physical examination. There's been more than one instance in the past where where we hear stories or have an M&M or something where we didn't have a good preoperative physical exam and we're not really sure how much of the nerve injury was present beforehand or afterwards. And so it's important to know that. I think particularly for sciatic nerve palsy, depending on the approach, you have to have a high index of suspicion for hematoma in the acute postoperative period, particularly because that's something you can affect and then which will affect the recovery. So if someone has an immediate sciatic nerve palsy, I actually have a fairly low threshold to obtain cross-sectional imaging to look for a large hematoma, especially if they have risk factors for it. We use neurodiagnostic studies really kind of late in the game, and they don't necessarily help us that much with sort of long-term treatment, but often a lot of patients sort of want to know exactly sort of where and how it's coming from. And whether or not there's any recovery. So in terms of treatment, what might be some immediate treatments if you have an apparent nerve injury after a total hip?
I have a quick question back to
Yeah.
diagnosis real quick. What is your opinion on the ideal cross-sectional imaging? Is it a CT with contrast?
Yeah, it's a good question. I don't think you necessarily have to have contrast. If these patients are in the acute postoperative setting, they're at a little bit higher risk for renal injury anyways. And so loading their kidneys with contrast may not be the best thing for them, especially if you think they're going to take them back to surgery. So I think you can actually get similar information in a CT without contrast. That being said, if you suspect sort of an active bleeder and a vascular issue, then you're going to need to get it with contrast. MRIs obviously take longer and are a little bit harder to get, so probably a CT with or without contrast. I don't know, Jeff, you have any further thoughts on that?
No, not particularly.
Also, one question: when would you get the neurodiagnostic studies?
Yeah, that's a question that kind of comes up a lot. they say it can take, depending honestly on which study you read and who you ask, and the degree of injury to the nerve, it can take 3 months or more for neurodiagnostic studies to show certain nerve changes. I think the more sort of important question to ask is whether or not it's going to change your treatment, right? So, or whether or not it's going to change your investigation. So the thing where it may come up the most importantly is if you have someone who has a prior history of spine issues and has some kind of numbness or weakness prior to the surgery, and then that gets worse after the surgery, and you want to sort of see how much, you want to be able to help the patient and their spine physician determine how much of it might be coming from the peripheral part of the nerve or from the proximal part of the nerve, and they can be a little bit helpful in that. But generally, we wait a while. I don't know, Jeff, do you have a specific criteria for wait or a specific time course for waiting? I usually won't get it before 6 months even.
This luckily hasn't been a very common occurrence. I haven't had to do it in practice, but I'd wait a long time.
Yeah. It's also it's rarely going to change your treatment course, so don't often order them.
It's more to get information whether you think the nerve is coming back, right? Not that it would change.
Yeah, somewhat. Some patients really like to see it. To be honest, half the time I order them is because someone told the patient about it, and then they really want it ordered. And often when you have a patient who has a nerve injury, you kind of tend to do what they want, because you're really trying to make sure they feel well taken care of. Bluntly, I don't have very many examples where the neurodiagnostic study actually changes our treatment management, with the exception if you think there is something going on with the spine as well. So what do we do? Let's say a patient has a foot drop after surgery on their post-op check. What's sort of the first thing that you might do?
Extend the hip and flex the knee.
Yeah, why?
Because that'll take tension off the course of the sciatic nerve.
Yeah. How about if their quadriceps is out?
Flex the hip.
Yeah, right. You want to take tension off of the nerve, right? So, reduce traction on the nerve. And then if you do diagnose a hematoma, then you actually want to evacuate that urgently. As we all know, nerves don't take being sort of compressed very well for very long. I had a patient who I washed out on call last year who had a regular posterior hip, gone to a sniff, and then their INR the sniff hadn't taken very good control of their INR, and their INR jumped, and they had a giant hematoma in the back of their hip, and they developed a sciatic nerve palsy at the sniff 4 days after surgery because of this bleed. And we didn't really get the call until 2 days later, and they had a giant hematoma which we washed out in the middle of the night, and the nerve never came back. If there's a hematoma, you want to take it back the same day.
And you put a drain in that?
I put 6 drains in it, but yeah.
Dr. Ward,
Yeah.
with metal artifact from the CT, how easy is it to see this hematoma that might be clinically significant?
And it's a really good question. Some of it's based on your index of suspicion, right? In the sense of if you have a patient who has a risk factor, if they're on an excessive anticoagulation, if they're on a 10A inhibitor, so some of it's based on your index of suspicion. But in general, if the hematoma is relatively large, you can still see it on CT. I should have put a picture up of that particular patient, but I honestly couldn't remember her name. It's so long ago, and she wasn't my primary patient, so it wasn't subtle. It was huge when it was there. So even with the metal artifact, it's usually, if it's big enough to cause a problem, you can see it. At least that's been my experience. Oh, that's a good question. How about for delayed treatment? I mean, there honestly isn't that much we can do. So some people advocate for neurolysis. That's relatively controversial. There are some rare case reports where the nerve was actually transected. I think, Jeff, you were telling me about one of your co-fellows, his first year in practice, like someone cut through the sciatic nerve with a saw while doing the neck cut or something like that.
Yeah, no, it was so one of the years ahead of me, the guy was in practice doing DA hips, and the resident on his service went so deep with the saw cut, he transected the sciatic nerve from a DA hip saw cut.
But not ideal. But I guess in those cases, you would actually repair a nerve. Hopefully that wouldn't necessarily be delayed, but if you did, you could try it. But essentially, the mainstays of any delayed treatment for a nerve injury are really bracing and physical therapy. Prolonged physical therapy can really help, and bracing can give good functional outcomes. As you mentioned before, for sciatic nerve palsy, that's an AFO. But for femoral nerve palsy, it's really some kind of drop lock brace, and they often need a gait aid in addition to that. So, whoops. Sorry. All right, so let's move on to acute periprosthetic fracture. We're not going to get through everything here, but we'll get through what we can. So this tends to occur in about 1 to 5%.
Dr. Ward?
Yeah.
Dr. Ward?
Yeah.
Real quickly, this is Justin here. When would you consider going to a posterior tib transfer for foot drop?
Yeah, that's a good question. I definitely would refer it to my foot and ankle surgeons. I didn't mention that because it's sort of not like, it's not in my head, but that's definitely an important thing to consider. Part of that depends on how on the degree of the nerve injury and whether or not they are okay with the AFO, as well as whether or not your foot and ankle colleagues, based on based on sort of their, and this is where neurodiagnostic studies come into play, right? You need to make sure that their posterior tib is strong and they can fire it, and but it is something to consider. I haven't had a lot of well, we don't see these injuries that often. I had one patient who I can remember from actually my time as a resident where they hated the AFO and they really wanted to try the tendon transfer. The tendon transfer wasn't really strong enough to get them out of the AFO. So I think it depends on the patient. But honestly, I would sort of leave that question up for my foot and ankle colleagues because they're going to be better able to sort of answer that with the patient than I do. But I'll definitely refer them if it seems like that's a possibility for them, and if they can't live in the AFO, if they really hate the AFO. Again, the AFOs have become pretty low profile these days, so I haven't had a lot of patients who have really gone for that. Also, the majority of the sciatic nerve injuries that I've sort of dealt with in practice have been from big revision cases, and the patient, it's sort of the AFO is sort of the least of their problems in general. But it's a good question. Certainly a possibility for tendon transfer. In terms of femoral nerve injury, I don't think there's really a tendon transfer that kind of exists for that in any way that helps, at least that I'm aware of. But for sciatic nerve, there are some tendon transfers that are possibilities, but not a lot. In terms of acute periprosthetic fracture, it definitely happens. The femur much more commonly than the acetabulum. The risks include any pressed fit implant, anything that contributes to poor bone quality, age, diagnosis of inflammatory arthritis, happens more commonly in women. And there are certain stem and cup designs over the years that have had a higher incidence. As the stem and cup designs have evolved, the incidence that are specific to the stem and cup designs have gone down, but it's important to be aware of. So there is a Vancouver classification for intraoperative femoral fractures. I don't necessarily suggest memorizing this because I don't think it's actually that helpful. I think that it's a little bit more intuitive in terms of what you have to do for the fracture, but there is that classification. In terms of acetabular fractures, there's been a couple described classifications, either based on anatomic location or displacement time of diagnosis, but the Vancouver group has also come up with a classification that seems to make a little bit more sense to me. It's essentially type 1, 2, and 3. And type 1 is essentially a fracture that doesn't compromise stability of the component. Type 2 is one that might compromise it, but doesn't compromise it right then. And then type 3 is a displaced fracture, which by definition would compromise the stability of the component. Any classification systems sort of help you make decision making. So type 1 is essentially you don't necessarily need to change your implants, but you might want to change your postoperative weight bearing. But type 2 and type 3 you need to do something about. So in terms of preventing acute periprosthetic fractures, I wouldn't hesitate to cement a stem into poor bone. There's pretty good studies out of the hip fracture literature for cemented versus uncemented hemis that shows that the mortality really rises when patients have to go back to the OR, and a lot of that reason has to do with press fit implants causing probably unrecognized acute periprosthetic fractures that then cause a problem. I think you need to be relatively careful with reaming and broaching. That's probably what leads to the fracture in the first place. And then the next part is really being relatively careful with reduction and dislocation. As Justin experienced, was this last week, 2 weeks ago, when we were operating on this, we were trying to do this 93-year-old guy conversion, and I was trying to not have to do an acetabular component and give him a hemi. We fractured the anterior lip of the acetabulum as well as fractured the crap out of the femur when I was pulling too hard in the reduction. So, it's don't force it if you don't want to fracture. Also important to
Hey, Dr. Ward, can I ask a quick question? When would you consider doing prophylactic cabling, or what are your indications for that?
Yeah, so, if you're trying to press fit and you're just not loving the bone quality, just throw a cable around it. It's also, I definitely I know attendings who essentially put a prophylactic cable around anyone of a certain age. I don't think there's a very clear algorithm for it in terms of whether you should or you shouldn't, but I think having a low threshold to put a prophylactic cable around things is just fine. I'll do that often in revision settings. In primary settings, if someone has really poor bone quality, I definitely have in the past. And I'll do that even if I'm planning on cementing, but just to prevent the fracture with the broaching.
Got it. Thank you.
Yeah. Also important, you don't want to underream the acetabulum by more than 2 millimeters. That's an identified risk factor for an acetabular fracture. And you want to pay attention to your implants and your templating. So you want to think about small patients, abnormal anatomy, patients who have been short for a long period of time. For this particular patient, that probably contributed to this too. He had been short for he had been short for 6 months, a lot of scar tissue. And then there are definitely patients who have sort of, the classic one are sort of patients with flexion contractures, who you're dealing with, and then you fracture them when you try to reduce. All right. So in terms of diagnosis at the time of surgery, you want to have a really high index of suspicion intraoperatively. If you are not getting stability out of your component, don't just think that, oh, I just need to broach up a size. Make sure you haven't broken something. If your broach or your final implant all of a sudden sort of sinks a little bit easily where it didn't before, check yourself and make sure you don't have a fracture. And then also examine your canal very carefully if your broaching just seems to be starting to be a little bit out of range with where your component templating was, because that can be a clue that you are broaching in the wrong direction in kind of a really bad way. What you want to avoid is getting the really bad PACU x-ray that just makes your heart sink, right? So if you have any suspicion, if you don't normally take intraoperative x-rays, but I think everyone Jeff and I do, take intraoperative x-rays for almost everybody. Make sure you just take the time to get an intraoperative x-ray, because what you don't want, this was a primary total hip that one of my co-fellows did in fellowship, when talking about this case afterwards, he was like, yeah, the cup wasn't quite as stable as it normally was, so we threw a screw in there, and then it seemed fine, and then this is the PACU X-ray. All right, so you don't want to get that X-ray in the PACU. This went on to fail and required a cage for what was previously a standard total hip replacement. Also, if you see a crack in the calcar, really take some time to investigate to make sure how far it goes. If I kind of go back to this case here, these two cables down here actually weren't around fracture, but because we were trying to investigate to see how far the crack went, we were feeling the linea down here. We really kind of dissected. I even called in UTCU to make sure that it was just linea, to make sure that we really got the extent of the fracture, because you don't want to cause a worse problem down the road. And if your broach really doesn't seem to be the right size, make sure that it's not this. This is not a PECU X-ray you want to have. So, I mean, I know it seems insane that this could happen, but I'm pretty sure Jeff has seen these too. Every once in a while, get referred in. So
that's not a fracture. That's just a airball.
That is someone broaching outside of the canal. Like through the femur, outside of the canal. So it is.
You can tell they felt something was off, right? Because they got that big old long head on there, and they're like, this doesn't feel quite right.
Right. So I mean, it's crazy that anyone would think that this would be something that they wouldn't figure out intraoperatively, but this is a PACU film, and you can see the staples on the side of the hip, right? So, you really, you don't want to get into this. You don't want this to be your PACU film, because even though this problem sucks, this is correctable. But all of a sudden, you have to take the patient back to surgery and fix it, and that's a whole different sort of ballgame than fixing it right then and there. Increases the patient risks, everything else.
For that case you showed us where the acetabular component was protruding into this one, intraoperatively, you're not going to have a cage there. So, I mean, what would you do differently other than get through the case and then, come back another day to fight?
That's a good question. So we'll talk a little bit about this with some acetabular fractures, but this wasn't my case, but if you diagnose this intraoperatively, then you want to be able to assess sort of your stability. So at this point, what I would do is I would take out the stem. I would take out the acetabular component, because the stem isn't ingrown yet. You just put that stem down. So take it out, and then really examine your acetabular fracture and see what you've done. If you've just poked a hole in the medial wall and there's an intact rim, then normally, even though you may not have a cage around, you may actually have revision style cups. So you could get a revision style cup, ream up, put a bigger cup in, put screws up and down, and limit weight bearing, just like you would do for a Poprosky medial wall defect with an intact rim. If you have blown out the columns and actually cause a transverse fracture, then you may actually need to pull the components, close the patient up, and then, if you don't have components in the hospital, wait a day until you actually have the stuff you need to reconstruct it. It's better to do that than to just sort of leave this, not be sure it's stable, and let it fail, because then you're causing worse problems. Right? You're causing more bone loss. So let me show you an example of that. So in terms of treatment, we can talk about this a little bit in the last few minutes that we have. So basically, for the femur in general, and for the acetabulum, you want to obey fracture principles, right? So go back to Dr. Tuba's lecture about sort of periprosthetic fractures. You can use cables, plates, and implants as your fixation method. Sometimes you can use allograft for the femur as well. But in terms of the implants, you can think of the stem as like a nail, right? And the socket is kind of like a bridge plate for the acetabulum. Basically, the other important principle to remember is that non-displaced or minimally displaced fractures may displace unless you do something about it. That either means using more fixation with a bigger cup and more screws. It means limiting weight bearing, and you definitely want to bypass cortical defects. You don't want to leave them and sort of assume that they'll be okay, because you are creating a stress riser, and there's pretty good. Jeff and I've seen plenty of cases where where something fractured through that cortical defect. Just some examples of sort of acetabular fractures. So this is kind of the one, an analogous to maybe that previous one up top. This is from a paper. This isn't our case, but Basically, they cause a fairly significant acetabular fracture, posterior wall, anterior wall, maybe some kind of including a transverse component. They took the components out, got their trauma surgery colleagues to help them. Basically, were able to fix the fracture and then put in a revision style acetabular shell and primary hip the next day. This is an intraoperative fracture. I don't know if Ilya remembers this case. This is like my first year in practice, like, I don't know, 6 months into practice. I was doing this horrible revision, and I underestimated the amount of sort of hidden bone loss of the osteolysis. And then when I impacted the cup in, I caused this medial wall defect. Now, we saw it on the intraoperative X-ray. The cup was very stable, and it's a revision style cup. So based on those principles, I sort of added a bunch of screws, limited the weight bearing, and she went on to heal. This had some consequences to it in the sense that I had to make up her length and offset with this collared neck. If I were knowing what I know now in practice, if I were to go back, I actually probably would have taken this cup out, and I might have actually have caged this just for safety. I think I got lucky with this, to be honest, but hard to say. This was a case I did. This didn't present to us as an acute fracture, but this presented later to me. But I think this was an acute fracture that the surgeon missed in the operating room or on the PACU films, because this patient didn't suffer a fall or anything like this, and came like this at her first follow-up, and then was sent to us. And she had a transverse fracture that required us to essentially use a distraction technique and kind of use the cup as a bridge in between the two. She ended up doing fine. But, all right, we're about close to time. I had a bunch of other stuff that we didn't get to, and realized this would all take so much time. I'll upload this to Box, but sort of talk about HO a little bit, and some different HO cases. Limb length discrepancy. In the last couple of minutes before Dr. Hansen's lecture, any particular questions about this? I know we didn't get to cover a lot. Each of these could be in their own lecture, but hopefully what we covered was useful.
I have a quick question. If you go back to the X-ray, of those final X-rays you were showing of some of those complicated acetabular fracture cases.
Yeah.
Like if you look at some of the, we spent a lot of this talk talking about vascular injury and where you're placing your screws. And in some of these revision cases, I mean, you've got screws that look like they could be, anterior, inferior, like dangerous places. So how do you go about doing that?
Yeah, I mean, so, again, so part of it's remembering the direction of your screws, right? And kind of where you are. So, if I were to go, I was trying to put as many screws in this cup as I could, but if, look, based on projection, like this screw is probably not doing anything, and it's probably not necessarily the wisest screw in the world to place. It's not anterior, it's more sort of medial, but definitely not like the wisest screw to place. I wouldn't place this one again. This one is long and in a aberrant direction, so, I didn't measure this screw particularly well. But I think at the end of the day, I actually exchanged it for a shorter screw based on this X-ray. So you definitely have to be careful about placing your screws. Looking at this one, so these are really, these are inferior. So you are risking the obturator a little bit here. But if you want to get any bite into sort of this bone down here, I was going for the screw being a little bit longer in order just to make sure that it was past the drilling part of the screw. These screws are all good, right? These screws could potentially be shorter, but then they also wouldn't get maybe any bite. So, it's hard to balance sort of your screw fixation and the need for screw fixation in acetabulum versus the risk of injury. That's also why, that's also why we, you always hear us talk about the home run screw, right? That's the screw that's up the medius pillar that actually gets bite, right? So in orienting our screw holes here, we were able to get 2 long screws up the medius pillar that are actually in bone, that get really good bite. This cup is also a lock-in shell. It has lock-in screw holes, so that helps this construct work. But you will see plenty of acetabular cups with sort of what appear to be aberrant placed screws. If a screw is a little long, it's not the end of the world as long as it's not long in the wrong direction, right? So, but it's a hard balance. I mean, you don't want the, and I know when, I mean, the cup cage that we were doing a couple weeks ago, Justin, Peter, and Jeff remember, it's like we reoriented the cup a couple times just to get the screws in the right place. So that's a good question. It's a little bit tricky to balance. So you want to be very, very careful with vascular injury. And I probably, I think in my first year of practice, I probably, put some screws into places that I wouldn't put in now, even if it risks the cup failing. So. I'll upload this to Box. Sorry we didn't get through kind of a lot of this other stuff, but hopefully what we got through was helpful.
Yeah, thank you.
Thanks, Dr.
Right. Thanks, guys.